Then classification, what are the different types of hemoglobinopathies that we find? There are two main types, two main classes of hemoglobinopathies. One are the qualitative defects of hemoglobin synthesis, and the second are the quantitative defects of hemoglobin synthesis. In the qualitative defects, hemoglobin is not synthesized normally, meaning an abnormal form of hemoglobin is being synthesized. One example is sickle cell anemia, where hemoglobin S is formed instead of the normal hemoglobin A. There's another disease called hemoglobin C and another disease called hemoglobin M or methemoglobinemia, in which instead of the normal adult hemoglobin A, hemoglobin M is formed. So these are all qualitative defects of hemoglobin synthesis. That is, hemoglobin is being synthesized, but not the right normal type. It is an abnormal type. Then the second type of defects are called the quantitative defects. Here, the hemoglobin that is being synthesized is in an inadequate amount. Why? Because certain chains of globin are not being synthesized adequately. This disease is called thalassemia. Thalassemia is again further subdivided into two types, alpha thalassemia and beta thalassemia. In alpha thalassemia, the alpha chains of hemoglobin are not synthesized adequately as much as they should be synthesized normally. In beta thalassemia, the beta globin chains of hemoglobin are not being synthesized. Then they are further subdivided into subtypes, thalassemia minor, thalassemia major, etc. We are also going to study the genetic abnormality in these diseases, the biochemical abnormality, signs and symptoms found in the patients in these diseases, how we diagnose this disease, and finally, what is the management of these patients. Normal adult hemoglobin is called hemoglobin A. 96% of the hemoglobin in an adult is of this variety. It is called hemoglobin A. It consists of 2 alpha chains and 2 beta chains. About 2.5% of adult hemoglobin in a normal adult is of a different type called hemoglobin A2. This consists of 2 alpha chains, and instead of the 2 beta chains, there are 2 delta chains. And only 1% of the hemoglobin in a normal adult is called hemoglobin F, which consists of 2 alpha chains, and instead of the 2 beta chains, we have 2 gamma chains. Abnormal variants from this hemoglobin, the normal pattern of hemoglobin, that is normal. But we do find abnormal variants also, which are seen in the hemoglobinopathies, which we have just discussed, hemoglobin S, hemoglobin C, hemoglobin E, and there are many other types. Increased hemoglobin A2 is diagnostic for beta thalassemia trait, where we find an excess of this type of hemoglobin. And what is the reason for that? The reason is a lack of the synthesis of beta chains. So we find more of delta chains taking up their place. Hemoglobin H, which is called a tetramer of beta, and hemoglobin Barts, which is called a tetramer of gamma, are seen in alpha thalassemia. Because in alpha thalassemia, the alpha chains are defective, and thus there may be a tetramer of all beta chains. All 4 chains of globin in hemoglobin molecule may be just beta. This is called hemoglobin H. And in hemoglobin Barts, the tetramer consists of all gamma chains. So these are seen in alpha thalassemia when the alpha chains are defective in synthesis. So coming back to hemoglobinopathies, what is the definition? These are genetic disorders which are caused by the malproduction of hemoglobin. And as we have discussed, this malproduction could either be qualitative or it could be quantitative. Qualitative hemoglobinopathy means that the hemoglobin that is being synthesized in this patient is structurally abnormal. It does not match the normal hemoglobin, it is abnormal. And here we have the different diseases which fall in this category. Sickle cell anemia, in which the hemoglobin is called hemoglobin S. So it's also called hemoglobin S disease. Then we have hemoglobin C disease, hemoglobin SC disease, which contains a mixture of hemoglobin S and hemoglobin C. Then methemoglobinemia. In the quantitative hemoglobinopathies, where there is a decreased production of hemoglobin, this includes the thalassemias, alpha thalassemia and beta thalassemia. In alpha thalassemia, inadequate alpha chains are being synthesized. Beta-thalassemia, inadequate beta chains are being synthesized. Both are then further subdivided into thalassemia minor and thalassemia major. Thalassemia minor is also called the thalassemia trait. And in thalassemia major, there are full-blown signs and symptoms in the patient. So this is therefore the classification of hemoglobinopathies, qualitative defects and quantitative defects. Let us first discuss the qualitative defect, sickle cell anemia. Sickle cell anemia is more common in the African race. It's very common in the African Americans. It's very common in the Negroid race, etc. This little baby is suffering from thalassemia major, and as you can see, she has come to get a blood transfusion. So sickle cell anemia is of two types again, divided into two further subclassifications: homozygous sickle cell anemia and heterozygous sickle cell anemia. What is homozygous sickle cell anemia? This consists of two alpha chains, two beta chains, but they are of the S type. So the patient suffers from sickle cell anemia. In heterozygous, the person has inherited one normal gene and so is for hemoglobin, and so is making hemoglobin A, and one abnormal gene from the parent, so from one parent, so this hemoglobin is hemoglobin S. But in this case, the person is going to have a normal lifespan, except that we say that he's carrying the sickle cell trait. What is the genetic mutation in sickle cell anemia? Like we have already discussed, it is an autosomal recessive disease. Autosomal means both genders can be affected. Males, females, both can be affected. What does recessive mean? Again, it means that one gene needs to be inherited from both parents, then only will the child demonstrate the full-blown disease. Two mutant genes for beta chains of globin need to be present in the child in order for the child to demonstrate all the signs and symptoms of sickle cell anemia. What is the actual genetic mutation in sickle cell anemia? There is just one nucleotide which is altered in the gene. So this is called a point mutation. In the beta globin gene, where at position 6 glutamic acid is normally present, this is replaced by valine, valine. And when this happens, the amino acid is valine instead of glutamic acid. What is the difference? Glutamic acid, as we all know, is an acidic amino acid. Valine is not. And hence, this leads to the formation of fibers inside the red blood cell. And when these fibers start forming, initially they are glue-like, then they become firm. And this changes the shape of the RBC from the normal disc-shaped pattern, the biconcave disc, to this pattern, the sickle shape, because there are long threads of beta globin which have formed inside the RBC to make it sickle shape. And the problem arises when these sickle shaped RBCs try to pass through very narrow capillaries. In case of the normal biconcave discs of RBCs, they pass very easily through even the smallest capillaries. But these sickle shaped RBCs, they cannot pass, and so they cause a blockade out there. And when enough sickle-shaped RBCs get clustered and clumped out there, then what do? They cause complete blockage of that capillary. And if a capillary is blocked, ultimately what is it going to lead to? The area which is supplied by blood by this capillary, that area will get infected and infarct will form out there. These infarctions can happen anywhere. They can happen in the heart, in the spleen, in the liver, they can happen in the kidneys, they can happen in the muscles, even in the bones or even in the brain, giving rise to a stroke. So this is the problem in sickle cell anemia. The infant does not show any symptoms of the disease until the age of 5 or 6 months. Why? Because up till now, he has sufficient hemoglobin F. But at the age of 5 to 6 months, the hemoglobin F starts to be replaced by hemoglobin S. That is sickle cell hemoglobin. And then the patient starts showing signs and symptoms of the disease. So what is the genetic mutation in sickle cell anemia? That the 6th amino acid, which is normally glutamic acid, which is a polar amino acid, it's an acidic amino acid, this gets replaced in sickle cell hemoglobin by valine. valine amino acid is non-polar. And hence this forms hydrophobic protrusions on the beta chain that fit into the beta chain of another hemoglobin molecule. Another hemoglobin molecule develops a sticky patch, and this hydrophobic protrusion on the beta chain fits into that sticky patch. And this leads to the formation of clumping and the formation of long threads. So as you can see, this is normal hemoglobin. This is the DNA of normal hemoglobin. At this point, what are the three nucleotides? They are C, T, T. In the messenger RNA that comes and gets attached to it, therefore, what are the nucleotides? C is in response to C, the nucleotide in messenger RNA is G. In response to T in the DNA, the messenger RNA exhibits A. And in response to the next T in the DNA, messenger RNA shows A. So in the messenger RNA, we have GAA. Now GAA, when this translates into an amino acid, the amino acid is glutamic acid. So this forms normal hemoglobin. Here you can see the mutant DNA of sickle cell anemia patients. Here you see that the middle T or the middle T nucleotide is replaced by an A nucleotide in case of the mutant hemoglobin DNA. And when this is replaced by A, what will be the complementary nucleotide in messenger RNA? The complement to A is U in the messenger RNA. So now this nucleotide sequence in the messenger RNA becomes GUA instead of GAA. GUA codes for the amino acid valine, whereas GAA was coding for the amino acid glutamic acid. And so in the sickle cell hemoglobin, at the point where glutamic acid normally should have been, what do we have out here? Valine. How do fibers form now? Now you can see this is normal hemoglobin. And this is deoxyhemoglobin, right? In deoxyhemoglobin, you can see a sticky patch. In the mutant hemoglobin S, there is this hydrophobic area, hydrophobic protrusion. A hydrophobic protrusion on the beta chain is formed, and this hydrophobic protrusion goes and fits in the complementary sticky patch. And when these the globin chains go on fitting one into the other, this is how a fiber starts to form. You can see out here that one beta chain is fitting into the other beta chain. This beta chain is fitting into this beta chain through this hydrophobic protrusion fitting into the hydrophobic sticky patch. And this is how long fibers are formed. And when these long fibers are formed, this is a normal red cell. But inside the sickle cell, you can see fibers are forming. As more and more fibers form, initially they are in a gelatinous form. Later on, they become hardened. And when they become hardened, then the shape of the RBC has changed completely. From the normal discoid shape, the biconcave discoid shape, it has now changed into a sickle shape, meaning it is in an elongated, hard shape. And if this is the blood capillary, you can see that normal biconcave discs of RBCs, they just manage to pass through very easily. By squeezing a little, they pass into all the capillaries of the body to supply blood to the tissues. But in case of sickle cell RBCs, you can see how they are all clumping at this end, and they are closing off, blocking the entrance to the capillary. And when this capillary gets blocked, of course, what's going to happen to the tissue that is supplied, where the blood is supplied by this capillary? That tissue will die. It's going to become ischemic. And this leads to acute pain. And in fact, these are the crises which are encountered by these patients of sickle cell anemia. What is the mechanism of sickling again? Whenever oxygen concentration becomes low, as you can see out here, in deoxyhemoglobin, complementary sticky patches form. In oxygenated hemoglobin, when the hemoglobin is well oxygenated, you can't see any sticky patches. But when the oxygen level becomes low, then you can see these sticky patches forming even in normal hemoglobin. But nothing happens here. Why? Because there are no complementary hydrophobic protrusions. But in the mutant hemoglobin S, there are hydrophobic protrusions, which are going to go and fit into these complementary sticky patches. So when the oxygen concentration becomes low, hemoglobin S polymerizes. Deoxyhemoglobin exposes hydrophobic patches on the globin molecules. Valine, which is the hydrophobic side chain residue at position 6 of the beta chain in hemoglobin, associates with this hydrophobic patch. And so hemoglobin S molecules go on aggregating, forming fibrous precipitates. So at low PO2, low partial pressure of oxygen, hemoglobin S is going to polymerize inside the RBCs, forming insoluble fibrous polymers. First, it is in the form of a gel. It is still soft. Later, it stiffens. And when it stiffens, it distorts the cell into the shape of a sickle. And it blocks the flow of blood in the capillaries. This will lead to microvascular occlusion. This interruption leads to ischemia, which leads to acute pain and eventually death of the tissue cells which were supposed to be supplied by this capillary, and this is called an infarction. What are the symptoms in the patient? The patient develops chronic hemolytic anemia. Why? Because these RBCs, normal RBCs have a lifespan of 120 days. But these sickle RBCs, because of their strange abnormal shape, they get broken down very easily, especially in the spleen, splenic sinusoids. And so there is a chronic hemolysis going on most of the time. So, and the RBC's life is also very short, 10 to 20 days only. That's it. That's the lifespan of a sickle cell hemoglobin RBC. And also because the blood is oozing out, causing chronic hemolytic anemia all the time. So this leads to hyperbilirubinemia. So the patients start becoming yellow in color. This also leads to increased infections because the spleen develops infarcts. And because infarcts can develop all over, we can see there are kidney infarcts, there are even infarcts in the brain, which can give rise to ischemic strokes, etc., splenic infarcts, etc. So there's an increased chance of infection in such people. And lifelong episodic pain, which are called the sickle cell crises. There is organ infarction in the spleen, the kidney, the brain, etc. There can be chest pain if there are infarcts developing in the myocardium, stroke if there are infarcts in the brain, marrow hyperplasia in an effort to make more RBCs to supply more hemoglobin and more which can supply more oxygen to the cells. The marrow becomes hyperplastic, and we had seen the sign which can easily be seen in the skull of that patient. So what do we find? What are the signs and symptoms of sickle cell anemia? Pain in the abdomen when infarcts are happening, bone and joint pains if there are infarcts in the bones and joints, breathlessness because of the severe anemia, enough oxygen cannot be carried because there's inadequate hemoglobin to carry the oxygen, delayed growth and puberty because as tissues are growing, they need more oxygen, they need more blood, and that is not being supplied. Jaundice, a yellow colored skin. The child feels fatigue all the time because there is inadequate oxygen being supplied to the muscles. And there is fever, which may be due to repeated infections. There is pallor, great risk for infection. Adolescents and adults can develop ulcers on their legs if there are infarcts here. Chest pain if there are infarctions in the myocardium. Sometimes there are infarctions inside the retina, which can lead to poor eyesight and even blindness. What are the precipitants of sickle cell anemia? As we have seen that decreased oxygen is one of the biggest precipitants. If the child is flying in an aeroplane where oxygen pressure is low, or climbing a tall mountain where the oxygen pressure is low, or running a marathon where the oxygen pressure is low, or doing severe exercise where the oxygen pressure becomes low, in all these cases, this can lead to sickle cell crisis. Or either decreased oxygen or increased carbon dioxide, they both serve the same purpose. Decreased pH can also lead to a precipitation of sickle cell crisis. Increased BPG, because when BPG increases, it prevents the red blood cell or hemoglobin from releasing oxygen to the tissues. Dehydration, if there's a lack of water, again there is going to be more crisis of sickle cell anemia. Why? Because if there is a lack of blood, imagine in anemia, there are already fewer RBCs. Then if water is also less, then blood becomes, the entire blood volume becomes even more reduced. And hence there is more chance of sickle cell crisis. High altitude, example aeroplane, again because of low oxygen tension, So the curve shifts to the right in case of sickle cell anemia. At normal pH, this is the curve. Low pH, the curve shifts to the right. Low pH, high temperature, high PCO2, high 2,3-BPG, bisphosphoglycerate, all these shift the oxygen dissociation curve to the right, and hence less oxygen is given to the tissues, which leads to even more crisis of sickling. So this is what you observe in the patient. If there are infarctions in the hand, then the hand swells up, becomes edematous and becomes bluish in color. Ulcers can develop on the extremities. You can see infarcts on the tongue, and here you can see an infarct in the heart. This can give rise to severe pain over the myocardium, and this can happen if the patient is flying at a high altitude where the oxygen pressure is very low. How can we diagnose a patient of hemoglobin S disease or sickle cell anemia? Hemoglobin electrophoresis. When hemoglobin electrophoresis is performed, we find that there are two normal alpha globin chains and two abnormal beta globin chains. What is the abnormality? That the sixth amino acid is not glutamic acid but valine. Valine has replaced glutamic acid. Hemoglobin S is less acidic than hemoglobin A because glutamic acid is an acid. Hemoglobin S therefore migrates more slowly towards the anode compared to hemoglobin A. And all this is found in sickle cell trait and also in the full-blown disease. Then DNA analysis to find the exact mutation in the DNA. This can also be done to diagnose sickle cell anemia. So in sickle cell anemia, we find that hemoglobin S has an erythrocyte lifespan of only 20 days. Normal is 120 days. In this case, the RBCs survive only 20 days because of their odd shape, sickle shape. They go into these reticuloendothelial cells, splenic sinusoids, etc., and they rupture easily, giving rise to hemolysis and giving rise to low lifespan of RBCs. The strange thing observed is that malaria does not happen in patients suffering from sickle cell anemia. Why? Because the Plasmodium falciparum needs to complete its life cycle, a part of its life cycle in the RBCs. In this case, the RBC lifespan is only 20 days. The RBCs are so fragile. So the Plasmodium falciparum cannot complete its life cycle in the fragile, short-lived RBCs. So one benefit, so to speak, in such patients is that they do not suffer from malaria. How do we manage patients suffering from sickle cell anemia? Prenatal screening can be done for the hemoglobin S gene. Amniotic fluid can be taken from the amniotic cavity, and then hemoglobin S gene can be analyzed. So this is called prenatal screening. If the new baby has been born, then newborn screening, which is sometimes routinely done in some of the major hospitals. Here hemoglobin S can be detected by hemoglobin electrophoresis. Management of the patient is of course symptomatic. The patient should be kept well hydrated so that he does not go into such crisis. Of course, he should not be flying in an aeroplane. He should not be going to places where the oxygen pressure is very low. And if he develops these crises, he can be given analgesics. He can be given antibiotics to prevent the excessive infections that take place in such patients. Blood transfusion can be given to meet the acute acute anemia due to repeated hemolytic crisis and because of the small lifespan of RBCs and because of excessive hemolysis. So sometimes the patient will need blood transfusions. Blood and bone marrow transplantation is the answer to such patients, or gene therapy. This, of course, is curative. The rest are all symptomatic. The next disease we'll do is, we'll study is hemoglobin C disease, which is also called, why is it called C? Because this hemoglobin is called Cooley's hemoglobin. Here also, the beta globin chain is the defective chain. Again, at the 6th position where glutamic acid should have been, the glutamic acid is replaced, this time by lysine. Hemoglobin C therefore moves, and lysine, of course, we know is a positively charged amino acid. So hemoglobin C moves even more slowly to the anode than hemoglobin A or hemoglobin S during electrophoresis. These patients suffer from only mild chronic hemolytic anemia. Their RBCs do not sickle. They just suffer from mild hemolytic anemia all their lives. Then we have the next disease called methemoglobinemia. In the normal hemoglobin, in the core of the heme, iron is present in the ferrous state normally, but in methemoglobinemia, ferrous iron is replaced by ferric iron. Now the problem which arises here is that ferrous iron is the one which binds with oxygen. Ferric iron cannot bind with oxygen. So the hemoglobin carrying ferric iron cannot act as an oxygen carrier. Hemoglobin can get spontaneously oxidized, and so its ferrous can change to ferric. How? By reactive oxygen species or by certain drugs like nitrates, sulfonamides, etc. They change the normal ferrous iron to ferric iron by these oxidizing agents. However, normally there is cytochrome B5 reductase present, which reduces this ferric form of iron and changes it back to ferrous form. The problem that arises in methemoglobinemia is that methemoglobin, which is normally reconverted to hemoglobin by reducing systems in the RBC, that is NADH methemoglobin reductase, in methemoglobinemia these are not working as efficiently. And thus the iron which once it changes from ferrous to ferric, now it cannot change back to ferrous. It remains in the ferric form, and thus in the ferric form it is called methemoglobin. And this leads to cyanosis of the blood, blue coloration of the blood, RBCs, as well as blue coloration in the patient. This hemoglobin is called hemoglobin M, and mutation in the globin chain is called, will lead to this hemoglobin M. And the problem is that there isn't enough NADH cytochrome B5 reductase to cause the reconversion of ferric iron back to ferrous iron. So the reductase enzyme is missing or reduced in methemoglobinemia. What are the symptoms observed in the patient? The patient is cyanosed. He starts turning blue in color. Dark blue, sometimes we can call it chocolate blue. Brownish blue skin and membranes. When we take a sample of his blood, even his blood looks bluish in color, and we call it chocolate blue colored blood. Tissues suffer from hypoxia because of a lack of oxygen being carried by this methemoglobin. And this can lead to anxiety, headache, dyspnea, meaning breathlessness on exertion. Polycythemia. In an effort to overcome this lack of supply of oxygen to the tissues, the marrow starts forming more and more RBCs, but it still cannot meet the need for oxygen, because unfortunately the hemoglobin inside the RBCs is in the form of methemoglobin, which cannot carry oxygen. It can also lead to coma, and coma can lead to death. What is the treatment for methemoglobinemia? Exchange transfusion or hyperbaric oxygen. And the third thing that can be given is methylene blue. Methylene blue is the primary treatment which is given in the emergency room. 1 to 2 milligrams of methylene blue per kilogram body weight is made into a 1% solution in intravenous saline, and this is given to the patient in 3 to 5 minutes. Methylene blue is oxidized, and this reduces ferric back to ferrous. So this is how methylene blue works, that instead of ferrous being oxidized to ferric, methylene blue itself is oxidized, and thus it reduces the ferric form of iron back to the ferrous form of iron. Now let's move on to the next category of hemoglobinopathies, which are the quantitative defects of hemoglobin synthesis. These are called the thalassemias. These are also counted as hereditary hemolytic diseases. Why? Because the synthesis of either the alpha globin chain or the beta globin chain is defective. This is the most common single gene disorder found in humans. It is of two types, alpha thalassemia and beta thalassemia. Alpha thalassemia and beta thalassemia are further divided into two types. Minor, in which the patient is just a carrier. He just has a low level of hemoglobin all his life. Other than that, he has a normal lifespan. But thalassemia or major, whether it's alpha or beta, that leads to signs and symptoms, and the patient's life is no longer normal. We also have alpha 0 or beta 0 thalassemia, which means no globin chains are synthesized, or alpha plus or beta plus thalassemia, meaning reduced rate of synthesis of alpha chains or beta chains. So here we can see in alpha thalassemia an excessive amount of beta chains are formed, and in beta thalassemia an excessive form of alpha chains are formed. Where is the defect? In alpha thalassemia the defect lies on chromosome 16. The genetic error is of deletion. In beta thalassemia the defect lies on chromosome 11 and the genetic error is mutation. Thalassemia classification therefore can be done on the basis of globin chains or on the basis of inheritance. The genes for globin chains. These are beta globin genes found on chromosome 11. And we can find that there is one gene on either chromosome 11, and these two are going to make the beta globin chain. But for the alpha globin chains, the alpha globin genes are found 2 each on the chromosome 16. And so there are four genes which are responsible for the synthesis of the alpha globin chains in the hemoglobin molecule. Alpha 1, alpha 2, alpha 3 and alpha 4. Thalassemia can be caused by a variety of mutations, including entire gene deletion. So the entire gene may be deleted, or substitution, where one nucleotide can be substituted for another, or deletion of one to many nucleotides in the DNA. And here we can see the different types of mutations. This is a substitution mutation, the change of one amino acid, arginine, isoleucine, serine, whereas in the normal case it was arginine, valine and serine. Here we see deletion, arginine, phenylalanine and proline. And here we see an insertion, arginine, serine and phenylalanine. Why? Because in the messenger RNA we find for arginine CGC. So if there is CGC, in all these three cases, it will code for the amino acid arginine. If there is GUU in the messenger RNA, the amino acid it codes for is valine. Here there is substitution. Instead of GUU in the messenger RNA, we are finding AUU. So this codes for the amino acid isoleucine. So we call this substitution. The next one, of course, is normal. In deletion, what do we find? That the messenger RNA nucleotide sequence, a triplet nucleotide codon GUU, which codes for valine, here has been changed entirely to UUU, and this codes for the amino acid phenylalanine. And the third triplet nucleotide codon UCC, which was coding for serine, in this case it becomes CCA, which is coding for proline. So the whole protein is altered. In the first case, there is just one amino acid that has been changed, so it's called a substitution. But here the whole protein is altered. Argine, phenylalanine, proline. So it is so different from the original, which should be arginine, valine, serine. In case of this type of mutation where there is insertion, what do we find? The first one is, of course, in the messenger RNA, the code was CGC. So the amino acid was arginine. Here we find the same thing. But in the second triplet nucleotide codon, in messenger RNA, normally it was GUU code, which coded for the amino acid valine. Here it becomes AGU. So the A has been inserted, AGU, and this codes for serine. So the next U out here has gone ahead. So instead of UCC, now it has become UUC, which is coding for phenylalanine. So here also the whole protein has become altered by the insertion of one single nucleotide. What is that one single nucleotide? This is that one single nucleotide that has been inserted out here. And in the deletion sequence, what do we find? that this is the nucleotide which had been deleted, and so the entire triplotype nucleotide codon had been shifted one place up. So it became UUU, and then it becomes CCA. So here also the whole protein is altered. Here also the whole protein is altered, whether it's a deletion of a nucleotide or an insertion of a nucleotide. But in case of substitution of a nucleotide, we find that the change is only of one amino acid. First of all, let us study alpha thalassemia. In alpha thalassemia, the synthesis of alpha globin chain is decreased or it is absent totally. And here we find that it's a deletional mutation, that there is a deletion of a nucleotide taking place. Alpha 0 means no alpha globin chains are being synthesized. Alpha plus means few alpha globin chains are being synthesized. Each individual normally contains 4 copies of the alpha globin chain coming from the 2 chromosome 16s. So in one chromosome 16, alpha 1, alpha 2 genes are present. In the other chromosome 16, alpha 3, alpha 4 genes are present, which are going to code for 4 different amino acid sequences, which will give rise to the alpha chains, alpha globin chains. Each chromosome 16 therefore has 2 genes. It is called HBA1 and HBA2, which gives rise to 2 copies of HBA1 and 2 copies of HBA2 gene in each cell. Each copy is called an allele. Therefore, there are 4 alleles that produce alpha globin. Each of the 2 genes produces one allele is inherited from the father of the child, and one allele is inherited from the mother. So each child inherits 2 alleles from each parent. If there are loss of some alleles or loss of all alleles, then different types of alpha thalassemia take place. If there is one mutated allele only, then the patient is just a carrier, will not show any signs or symptoms. If there are 2 mutated alleles, then we say that the patient is suffering from alpha thalassemia minor or alpha thalassemia trait, and he will just show mild signs or symptoms of alpha thalassemia. If there are 3 mutated alleles, then it's called hemoglobin H disease. A tetramer of beta globin chains will form, and this can lead to moderate to severe symptoms. If all the 4 alleles are mutated, then this is called alpha thalassemia major or hydrops fetalis, and this affects the fetus. The fetus is stillborn, or if he is able to be born as a living newborn, he is not going to survive too long after birth, because this type of 4 mutated alleles of alpha is totally incompatible with life. So in alpha thalassemia, what are the genetics? That if 4 genes are normal, that is, the genotype is alpha alpha from one chromosome, alpha alpha alleles from the other chromosome, then the person is normal. If there are only 3 genes which are normal, then the genotype is alpha alpha and dash alpha, because one allele is missing. So this patient is called a silent carrier. If 2 genes are affected, then the genotype is dash alpha and dash alpha, meaning there are only 2 alleles found, one from each parent. This is called alpha thalassemia trait. If there is only one gene which is producing the alpha globin chains, then we say that the genotype is dash alpha and dash dash, meaning only one allele is present. So this is called hemoglobin H disease. This patient is going to show severe symptoms of alpha thalassemia, because all its 4 globin chains are beta. And if there are a 0 number of genes of alpha globin chain present in the genotype, then the genotype will be minus 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 minus, meaning no alleles present. Then the hemoglobin is called hemoglobin Bart's. The child is said to have hydrops fetalis and he cannot survive. Alpha thalassemia, therefore, the level of deficiencies, if only one gene is defective, then the patient is a silent carrier. There are no physical manifestations. If 2 genes are defective, then we say that the patient is suffering from alpha thalassemia trait. If 3 genes are defective, then we call it hemoglobin H disease, and the patient has all 4 of his globin chains are beta type. There is no heme-heme interaction. The curve or hemoglobin dissociation curve is hyperbolic. Very high oxygen affinity will fail to deliver oxygen. If all 4 genes are defective, then it is called hemoglobin bars, because here all the 4 globin chains are going to be the gamma type. And the child suffers from hydrops fetalis. This leads to fetal death either in utero or just after the child is born, because alpha chains are definitely required for the synthesis of even hemoglobin F. Now we move on to beta-thalassemia. In beta-thalassemia, the synthesis of beta-globin chain is decreased or absent. And in this case, there is just a point mutation, meaning one amino acid is different only. So there is decreased messenger RNA for the beta-globin chains. The alpha chains in this case are normal. There are only 2 copies of the beta-globin gene found in each cell on chromosome number 11. So this is the picture of a normal type of a DNA, and this is the mutant type of DNA, where we find that only one nucleotide is different. One nucleotide has been changed. See here. It has changed from T to A. In the normal type, there was A found in the messenger. In the DNA, there was T. So in the messenger RNA, there was A. And in the mutant DNA, we find that in the DNA, there is A. So in the messenger RNA, of course, there's going to be U. Okay. The pathology of beta-thalassemia is that the alpha chains are being formed normally, but they cannot form a stable tetramer, and hence they are going to precipitate to cause premature death of the RBCs. There will be an accumulation of hemoglobin A2 type, that is alpha 2 delta 2, and hemoglobin F, that is alpha 2 gamma 2. In beta-thalassemia, each individual contains 2 copies of the beta-globin chain. The level of deficiency is seen here. If one gene is defective, then it is called beta-thalassemia minor and or beta-thalassemia trait, and there are no physical manifestations in the patient. However, if both genes are defective, then it is called beta-thalassemia major or Cooley's anemia. As beta-globin gene is not expressed until late fetal gestation, so the physical manifestations of beta-thalassemia are only going to appear after birth. Symptoms will appear several months after birth. It may be that the child can become 1 to 2 years old, and then only will the symptoms start appearing. And what is going on in his body? Ineffective erythropoiesis, meaning RBCs are not being formed adequately. So this leads to severe anemia and skeletal changes. There can even be extramedullary hematopoiesis. You can see chromosome 11, which is responsible for the 2 beta globin genes. And these will then give rise to the beta chains in hemoglobin. Classification of beta-thalassemia. Beta-thalassemia minor or beta-thalassemia trait. Here the genotype is B, B+, and B, B0. Meaning one of the beta alleles is normal, which is inherited from either parent, but the other one is either not producing adequate amounts of beta globin chains, or it is not producing any, 0. The clinical severity in this case is he is just a silent carrier. Beta-thalassemia intermedia, where there will be moderate signs and symptoms, and beta-thalassemia major, which is B0 by B0, meaning that he just has one normal beta-thalassemia, normal beta-globin chain, but the other one is not being produced at all. So this will lead to severe beta-thalassemia. The infants that are born with beta-thalassemia major seem to be healthy at birth. Why? Because at birth there is still hemoglobin F or alpha 2 gamma 2. This is the composition of hemoglobin F. But during the first or the second year of life, they become severely anemic. And this anemia is of the hemolytic anemia variety. And this also leads to jaundice in the patient, splenomegaly, and growth becomes stunted because enough oxygen is not being supplied to the tissues due to a lack of hemoglobin. Here you can see that these are normal red blood cells, but in beta thalassemia, there are abnormal erythroblasts, with insoluble alpha globin aggregates inside the erythroblast. And here you can see that in a red blood cell, which is hypochromic, alpha globin aggregates have started to form. And in the skull, of course, hair on end appearance. And here you can see, because of repeated blood transfusions, the iron starts getting deposited in the various organs of the body, leading to systemic iron overload. But other than that, the child suffers from anemia, and he may need to be given repeated blood transfusions. So the treatment of beta thalassemia is just giving blood transfusions, but this can lead to iron overload. This can lead to iron overload, leading to hemosiderosis, that is the deposition of iron in various organs of his body. The treatment or management is, of course, bone marrow replacement therapy and hematopoietic stem cell transplantation. So that is all about today's lecture. So we have discussed the hemoglobinopathies, qualitative defects and quantitative defects. In qualitative defects, we find that the hemoglobin that is being formed is abnormal, and in the quantitative, and that includes hemoglobin S disease, which is sickle cell anemia, and also methemoglobinemia. And then we have the quantitative defects of hemoglobin synthesis, which are the thalassemias, in which less globin chains are being synthesized. So this is of two types, alpha thalassemia and beta thalassemia, depending upon which globin chains are not being synthesized adequately. And both of these are further subdivided into thalassemia minor, where the patients are merely carriers. They do not exhibit signs and symptoms, or whether the patient is suffering from thalassemia major. In this case, of course, there is a full-blown disease, there are signs and symptoms, and the normal lifespan is not achieved. The patient suffers repeat